This
to
conference will now be recorded.
We're pleased to have with us today Coleman Smith and Matt Simon from Informatics. We've done a lot of work with Informatics over the years, and this past year especially, as we've done some strategic planning with them. And we felt it was important for them to talk about some of the national regulatory changes that we're all facing with the 21st Century Cures Act. So again, I just would ask everybody, please go on mute, and Bobby will put Coleman into the driver's seat as our presenter, and we will get started. So Coleman, I'll hand it over to you.
All right, good morning, everybody. Hope everybody's doing well. We are, and I appreciate the introduction. We're going to have 20 minutes to walk through this, but I want to make sure that I offer this up. If anyone has questions at any point in time, feel free to reach out to myself and Matt afterwards through phone or email. We're happy to talk through this. We're going to go through briefly the 21st Century Cures Act and the Patient Access and Interoperability Final Rule. The 21st Century Cures Act, the provision that we're going to focus on is information blocking. For the Patient Access and Interoperability Final Rule, we'll be focusing on the ADT event notification. There are multiple things in each one of these that are good to consider. And there are a bunch of other provisions that are involved in this. But as we talk through these things, you want to be thinking about regulatory timelines. Some timelines don't match up. We'll talk about that. You want to talk about some legal considerations that you need to take into account when this goes into effect. The data requirements and the way they change. We go from a limited data set, which is bigger than our current C-CDA that we exchange today, that is required, to the full designated record set. There's definitely some policy and process that from a health system perspective you want to be in tune with. And then you're going to want to talk about when and what available IT functionality you have today and when that kind of goes into place. So as we dive into it, at some point in time, I have no doubt that I will drive you to put your heads in your hands. I would like to remind everyone I did not write this rule. I'm only here to talk about it, and I'm happy to provide a virtual hug if needed. So the summary of this is this. Healthcare providers spent the last 10 years capturing data in EHRs, and that was the HITECH Act. That's what got us really all in this place, and I'm sure a lot of you guys know that. The 21st Century Cures Act is really going to push us to transmit that data. It's not that people didn't want to transmit that data in the past. It's just we've run into obstacles. The onus hasn't been there. Well, now it is. So the next decade, and clearly in the next several years, our focus is going to be how do we get the data that we've been capturing in a stratified manner out of the system and into other people's hands, into other systems. So the major provisions, these are the major provisions of the Act. And like I said, we're going to focus on information blocking, but they're important. And a lot of this deals with the way they have changed vendors in order to help respond to the information blocking provisions, the requirements of information blocking. And you'll see a little bit of that interlaced in the presentation, but know that, again, if you want to talk about those in specific, please let me know. But today, we're going to talk about information blocking. So this is our timeline. ONC put this together. The big thing that I always like to point out is the top part of this timeline is directly related to certification. It's all about the vendors, when they have to have their technology certified and in place. They may get it in there sooner, but that is applicable in many ways to the vendors. In the bottom half, what you see is the information blocking provision. This is applicable to everybody. I'll show you a slide in a few seconds, but just know when it says if you're in healthcare these days, you're under the information blocking provision. Vendors, actors include health IT vendors. It includes HIEs and HINs, and then it includes the laundry list of providers, ambulatory, hospital, inpatient, long-term care. It's everybody under the sun. So much so that and I'll show you this on the slide, the secretary has said, and anybody else I decide to put in there. So it's everybody. The biggest thing that I also like to point out is this USCDI data set, which I'll show you that in a few minutes. is what is required on November 1st for us to be able to exchange electronically or be able to exchange and claim some exclusions. But when your certified vendor is required to have the easiest way to provide that data is not until May 1st of 2022. So you're seeing already things aren't lining up. So understanding what we have today and when your vendor is going to be ready is really important. So for information blocking, we're going to talk about the definition. We'll talk about some considerations and elements of what would cause you to be an information blocker. We talked a little bit about the actors. We'll go into the exceptions, which are very important. And then we'll talk a little bit about compliance and penalties. So in regards to what it is, and they have a lot of definitions on this, but unless it's required by law, anything that is likely to interfere with access, exchange, and use of electronic health information. And they go on to say, and anyone who knows or should know. For those that are just in the provider, actor category, they limit it to no. But those that are in the HIE category, HIN category, health information technology category, it should know. So the risk is greater. If I were to offer my EHR, be an offer of cert, I think one example would be an Epic Community Connect. I now fall into the health IT vendor category. So my risk is higher. My compliance, what I have to comply with is higher because I can't just claim that I didn't know. I should have known. And so it's the act of doing that. So what is it that they're asking for? For the first 24 months, it's the US CDI data set. And I'll show you the slide that has everything on that. But after that, it moves to the full designated record set in your EHR, in your certified technology. Now, if you think about that, it's medical, it's billing, it could be anything under the sun that they can ask for. This is the part where most people put their heads in their hands and say, how are we supposed to do that? So I can give you a brief moment if that's what you need to do. But and that's why the exceptions are important to take into consideration. So what does it mean to be an information blocker? We talked about this. They have 6 things they talk about to be qualified as an information blocker. The first is an actor regulated by the provision. We've already talked about that. Most everybody's going to be covered by this. So nobody's going to be out of this. You're going to be an actor. If you're on this call, you're more than likely an actor. And it involves electronic health information. So US CDI data set, full designated record set. It is likely to interfere with. So if I prevent it, I materially discourage it, otherwise inhibit. And there's a lot in the regulation that helps define and give examples around that. There's also a lot in the proposed rule that gives examples around that. And then it's on know versus should know. We touched on that a minute ago. They're not trying to get you in front of a federal or state law. I mean, if it's not allowed already, they're not saying you have to do it. And then also that it wouldn't be covered by an exception. Now, it's important to understand the exceptions. Again, like I said, we'll review the exceptions. But when the rule was written, the exception they state multiple times that the exceptions should be used. I don't want to say sparingly, but they should be used with precision. An example is if I'm not able to take out a piece of data, if I'm not able to subset out something I didn't want to send in the message, in the HL7 message or whatever transmission method you decided to do, that doesn't necessarily give you the right to claim an exception. They want the onus to be to provide the information. So if you're looking for which side they fall on, it's provide the information as much as you can, as best as you can, as opposed to claiming an exception. So actors, we talked about this a little bit. Healthcare providers, this is the full list. The one I thought about, that way I said it, and any other category, my thing's in the way, of healthcare facility, entity, practitioner, or clinician determined appropriate by the secretary. So a really massive amount of everybody's covered. Health IT developers of cert, this also were offerers of cert, and then health information networks and exchanges. So this is the definition for it when we talk about the designated record set as defined by HIPAA. You guys can look that up, but what you'll see is it's basically all the data in that regard that you define. So your system, your hospital system, wherever you're taking care of a patient, you may have defined the designated record set different from your neighbor, but it's going to be in the same. It's going to be in the same ballpark, and it's a ton of data. We talked about it being limited to the US-CDI data set until May 1st, but that starts November 1st. And then compliance, we talked about this for vendor certification of US-CDI functionality, which is more related to API stuff, but still, it's just the vendor certification for US-CDI functionality is not required until May 1st. Now, hopefully the vendors will be ready before then, but that's when it's defined to be. Now, we still have to examine any requests we get, and they can ask for it in a lot of different ways. But the easiest way to provide it, our vendors don't have to be certified for. So it makes it different from that perspective. Like I said, the timelines aren't lining up. This is the US-CDI data set. It's the US core data for interoperability standard. The things in blue are the things that are different from our current C-CDA. I want to call out the notes specifically. The time now to get in front of your physicians and clinicians and letting them know that their notes are going to be more readily available. Could I go get my notes today? Of course. I could go. It's a release of information. Of course, I can get that. But electronically and how they want you to transmit it makes it much easier for people to get access of this data. So being responsible for what our physicians put in the notes is very important. These other things, of course, are part of it from a US-CDI. So I always like to put these in there because listening to notes, listening to regulations makes you want to fall asleep or daydream or things like that. So if you haven't heard anything I've said, which is totally fine, remember these three things. When we talk about electronic health information, it is all electronic health information contained in the cert. It's the EPHI included in the designated record set, but it starts with the US-CDI. However, a response to all requests is required to provide a requested manner or claim exception. So just because your vendor doesn't have the same timeline as you to provide the US-CDI data set doesn't mean you can just say, well, I'm just not going to do it. You have to figure out a way to provide it in the way that they request it, or you claim an exclusion and provide a different and create a different way to provide it. It's not just one response method. Essentially, everybody's involved in this. So who's impacted? Everybody. And then I like to talk about this. It's required November 1st, which is it's like 60 something working days from now. Not that everybody doesn't work the weekends and things like that. So from a consideration standpoint, I would ask you to consider the following. Where are your US-CDI data or elements currently captured? Are they in different certified systems? And how are you going to address the idea of a request that comes into this? How are you going to communicate and educate across your health system? How are you going to currently support the ability to provide this information from HL7 interfaces, your current C-CDA? How are you going to bring in your exceptions to this? And we'll talk about the exceptions in a second. How are you going to support compliance? And this is just the bigger thing. It's a release of information. So getting legal on board, getting your health HIM departments on board, getting your information services department on board, and all the others in between to be able to pull this off by November 1st is a heavy lift. And then, of course, planning for the full designated record set. So what if I can't get all that data? Well, they do have exceptions for that. And this is where legal comes in. There are 8 exceptions. There are 5 for not being able to fill the request, and there are 4 for how you fulfill those requests. So to give you an example, preventing harm. I decided I didn't want my patients to have a lab result. Which happens in the past before I got a chance to talk to them. Well, I may want to look into the preventing harm exception. At the same time, what we talked about earlier, if I can't segment out that piece of lab data, that may not be a good enough excuse from your legal team, and the rule it seems to be written like that, for you not to provide all the data in a requested manner. Now, when they talk about when do you have to provide it, the other part about this too, they don't define timely access. There's a section in the rule where it specifically talks about the fact that timely access is, they're not defining it because they don't understand, they don't understand everybody's technology. They don't understand what your ability to provide the data is. So you're going to have to define those those things so that you can justify yourself if you ever were audited. Content and manner is an exception. That's more on the drive of, I wanted to provide it, but you asked it for in a way that I couldn't provide it, and you asked for data that I can't provide right now. So I am going to offer up a different way to provide that data. And that's where you work through the content and manner. Those are just 2 of the exceptions, but those are those 2 examples of it. And again, we'll provide the presentation so you guys can look through this. But you have preventing harm, privacy, security, and feasibility, and health IT performance. From health IT performance, an example there would be, we just have downtime. Somebody asks for something and I can't do it. It's okay if you have downtime. You're not information blocking. We talked about content and manner and fees and licensing. So what's compliance and penalties? ONC is going to develop a standard process for the public to submit reports. It does not exist yet, but they're in the process of doing that. OIG, Office of the Inspector General, will establish civil monetary penalties. You're not subject to penalties until the final rule is released, but they've already released a proposed rule back in April that touches on this. So I wouldn't be surprised if it comes out before November 1st or sometime in November. As we talked about, the higher risk for health IT developers, HIEs, HINs, from a monetary perspective, and for those that offer their certified technology, like a Community Connect from an Epic perspective. And we talked about this. November 1st is when it begins. Now, who is going to ask for these things? When we think about this, I don't know if it's going to be a lot of patients, but payers that have the right of their patients to ask could come in and ask for multiple patients. It's single or multiple. Providers who are moving from one system to the next could come in and ask for multiple patients. How are you going to handle those massive requests of data when you're required to handle those come November 1st? Again, things to think about, and probably putting your head in your hands. But again, we have limited time here. I'm happy to talk to you guys about this at another time, just to give you some things that we're helping people with. Think about this in other places and how they've handled this, because I do not want to create more stress, especially in this time. So, information blocking summary, the last three things. What is it? It's all about access, exchange, and use. Electronic information starts with the US-CDI data set. It moves to the full designated record set. A response to all requests is required. Again, everybody's impacted. And the US-CDI data set is required November 1st, 2020. The full designated record set is required May 1st, 2022. I'm going to turn it over to Matt for a few seconds, and then we'll summarize real quick of everything. And Matt's going to talk about the patient access and interoperability final rule, in particular, the admission, discharge, and transfer event notification.
That's right. Thank you, Coleman. And thanks, everybody. So I just want to take a couple of minutes and talk about the last part of the Cures Act, which is really very specifically focused on a specific process and a specific function of improving care coordination through data exchange. So, and the ADT event notification part of the rule, they determined was so important that they actually made it a condition of participation for Medicare. So any hospital, psychiatric hospital, or critical access hospital that is participating in Medicare or Medicaid and that utilizes an EMR, so pretty much everyone, is bound by this rule. But I do want to frame this a little bit differently in that this, especially as you're wearing both your hat as being part of a provider, but also as being part of an HIE, that this rule does represent an opportunity to help enhance care coordination across communities. So the rule itself very specifically says that the providers must be able to send notifications at the time of an event, an admission, a discharge, a transfer to the ED, and so on. And they must be able to send it to a provider that has been identified by the patient. So this is a process that you're all probably very familiar with. It's something that we've been talking about in healthcare for many years, and we know that there are a lot of processes behind this that are broken. There are a lot of technologies that we can use, but this kind of codifies the requirements there. And I think there's a couple of important things to note about this. The first is that the technical burden is intended to be low. Most, if not all, systems, EMRs can do this. They can send out the data when they're provided someone to send it to. So that is not where they're intending to create a lot of work. The bigger burden is on the processes. It's on being able to identify the right provider, being able to match patients appropriately, having back-end processes such as audit so that we can make sure that information is going out to the right provider. And the last thing, and you'll hear me say this a couple of times, is that this is also, this rule provides an opportunity. because it really it can be a strategic differentiator for health systems in that if they're able to support attributed populations and send additional information and make sure that they're actually enhancing workflows, it can make a big difference. So on this slide then.
We sequenced them, yes, Dr. Galliano. So I did get your response to that, and I sent that to her to see
if everybody can go on mute. There we go. So the next thing here is when we talk about some of the considerations, what I'd actually like to focus on here is the third point, which is about understanding who is the established recipient. As you know, it is often difficult to identify who the correct physician is. I think we've done studies with clients where we found that when you ask the patient who their PCP is or who the primary relationship with is, who the physician is, you'll get an answer maybe 50% of the time. So the good news on this is that from a regulatory perspective, you have to show that you have made a reasonable effort to capture that information, to get the appropriate physician or group from the patient, and that you have actually made an effort to get that into your notification system. If you make a reasonable effort, but the patient hasn't identified a provider, then you won't be held responsible for that. Now, that said, there is an opportunity. There are other opportunities to help identify the right recipient. The other thing that the rule does not dictate is how data must be sent or received. So again, the EMR really just needs to be able to send out an ADT. It does not tell you what system you have to use. If you don't necessarily have to use your own EMR, you can use an intermediary service. And it doesn't tell you how it must be delivered, what format, what structure. So these are all important things to consider as you're getting to how you're going to do this. So if you go to the last slide here, Coleman, thank you. So when we work with clients, and again, I'm thinking here in the context of both the hospital and as the HIE, and there are really a couple of things that you have to ask. First of all, we always go through and we want to make sure we understand the current process. And this isn't a technical process. It's what's your registration process? How do you do, what does your physician directory look like? How do you know how to get information out to the providers? And then, how do you deal with your audit and legal and compliance sort of issues around sharing data? What data can be shared? How do you want to share it? The most important question, though, is, strategically, what is the value that we're trying to provide here? So one of the things that we've predicted and that we see happening around in different markets is that there are going to be those that simply meet just the letter of the law and send out a very basic ADT that says, hey, you have a patient that was admitted or discharged. But what we're seeing is others who are going to either through their own technology or through in collaboration with third parties are offering additional services to enhance that data. And I think I mentioned this before. That's either, give me your attributed population, your Medicare Advantage populations, and we'll make sure that the providers are getting detailed notices with additional summary and other, notes for those patients. There are several other ways you can work with providers, the payers, the community, and you can really help strengthen the relationships within the state. This is also important with post-acute, making sure that you're alerting them and getting them the right information. So what we recommend, and as again, in both the context as the provider and the hospitals, to look at your local and your statewide options. I know in North Carolina, there are a couple of services that are offering notification services, and figuring out, how you can capitalize and collaborate with those. So that's all I have. I just wanted to kind of give you a very brief update. I apologize for going over a little bit. Coleman, anything to add?
Yeah, the last piece of this, and I apologize too. It's just because I like the slide. I just like the Matrix movies. But it's like all data to all people at all the time. That's what we're looking at in the future. And so there are other things that I really want to make sure. We talked about information blocking. We talked about the certain requirements a little bit. Guys, there's things in the way they're going to standardize the API program. The way you have to think about that is somebody comes in, they have an app, and how am I going to handle that? Who's going to know where to go with that and connect that app? And then who's going to monitor the security and the data? I mean, there are so many other things that are included in these rules, but in essence, it's all about getting the data. The nice thing about it, and this hurts my eyes even to look at, but it's like you're understanding where to start. Information blocking has the closest timeline. You know, you got a bunch of things to think about with this, but what I would, and I'm not going to make anybody watch that slide, is that at the end of the day, it's like I used to say eating an elephant, but who wants to eat an elephant? I just say eat a room of ice cream, and it's like the dairy-free kind, because that's the kind I can eat. Is like you eat a room full of ice cream one bite at a time. And so a lot of this is breaking down, where is the data? When do I have to have it out? Who can help me get it out? And who can help that process of understanding when I can't get the data out, where I need to justify myself from an audit perspective for both of the main things we talked about today. So I want to end on the fact that I hope everyone is doing well. I wish you all health for you and your loved ones. And thank you for the time today. We appreciate it.
Coleman, Matt, thank you guys so much. This is a huge topic, and I know there's been presentations that have been done that last an entire day. So scaling this down into 20-25-minute synopsis is pretty incredible. We will share your slides, and we will ask folks to reach out to you directly with questions. And again, we appreciate you being here today. So just staying on time here, it's time check, it's about 12:34. Our next presenters are on the line. We have Carol Owen and Jay Starr from Health Catalyst. They're going to give us just a really quick, maybe 10-minute or so brief update on the Health Catalyst product portfolio and all of the really great enhancements and value that they're going to bring to Coastal Connect over the next year. So I'm not sure who's starting, but Carol, I'll hand this over to you.
Thank you very much, Yvonne and CCHIE team. Thank you for inviting us here today. And thank you to, I think it was Matt and Coleman, for that very interesting presentation. That was a lot of data coming at us. And I know it quicked a lot of questions in my own mind. So, very, very informative. Jay, I think you're going to present the slides. Is that correct?
Yes, although I'm having a Mac security error that requires me to restart GoToMeeting to be able to share my screen. So.
All right, hang on, I can share it. If I could figure out where do I share and go to? I should have practiced.
And I'll go ahead and drop out and back in. If I beat you, I'll go ahead and share.
Yep. Hang on just one second, guys. We have the presentation. We both were ready to present should this happen.
Carol, we have your PDF slides if you want us to drive it from that.
Just give me just one more second. I think I've got it right here. Yeah, Yvonne, why don't you go ahead and do that? I apologize.
Okay. So Bobby will quickly pull
while you guys are, while you're pulling them up, I'll go ahead and get started because the first slide is really just a quick update with where we are. So again, my name is Carol Owen. I think I've been with CCHIE for the 10 years of existence. So we're thrilled to be your technology partner in this crazy adventure we've been on. And so wanted to just start with a couple of key takeaways regarding, I think many of you perhaps you aren't aware, and I should introduce it. And so just go ahead and advance to, I think it's the third slide. There we go. So thank you. Yep, keep going. Here we go. So just some key takeaways for today. One more that I wanted to touch on is Medicity was acquired by Health Catalyst, and it's actually almost to the day 2 years ago. It was July 1st was our 2-year anniversary since we became a part of the Health Catalyst family. If you're not familiar with Health Catalyst, they are a premier vendor in the analytic space with many provider organizations. And so, you know, we are often asked, well, gee, why was Health Catalyst even interested in acquiring an interoperability platform? And, you know, I think the story of COVID actually played out, exactly the quote unquote why Health Catalyst would be interested in an interoperability platform. And really, analytics require more and more interoperability capability. And I think that we see that very true of COVID and some of the use cases and the dashboards that we've been able to provide to our hospital stakeholders in that regard, and the need to acquire bigger data sets for ambulatory practices from payers, complementing claims data with clinical data. So that's, you know, some of the backdrop on some of the why. I'm pleased to announce that we're fully integrated. You know, sometimes when you acquire a business, the integration work is hard and oftentimes not successful. I would say that Health Catalyst, I'm very pleased with where we are from an integration perspective. Our technical teams are fully integrated. So you're going to hear from Jay Starr on our roadmap. Jay has responsibility for both interoperability capability and analytic capability. So I'm just very pleased with the state of bringing these two platforms together. And go ahead and advance to the next slide. And so Health Catalyst, what's been exciting about being a part of this organization is they are an extremely mission-driven organization. We review our mission at every team meeting, which we have a lot of team meetings, trying to be very communicative in the state of COVID and remote work. And so our mission is to be a true catalyst for massive, measurable, data-defined healthcare improvement. And so that's what we're about, and we provide for that in an analytic environment and in a complementary interoperability platform. So with that, I think we go over to Jay. I think I skipped past our agenda slide. Our next couple of minutes, we will, interestingly enough, share with you how Health Catalyst will be complying with some of those regulatory updates that we just heard from our previous presenter. And then we're going to step into some of the roadmap capabilities that we'll be providing in the next in our next updates, in our next releases. So Jay?
Perfect, thanks, Carol. Next slide, please.
And by the way, Jay, they're presenting their slides, so they might be slightly not our exact final.
That's okay.
But maybe they.
That's okay. So this right here, I want to call out really quick. I don't the dates on here. I know they don't quite show what Coleman and team was presenting. These dates right here on rows 1 through 3. They show a 3-month grace period that was granted by the ONC. So for example, the US-CDI definition, it does take effect on November 1st, but the US-CDI or the ONC team will offer, because of the global pandemic, a 3-month grace period on that. So that's the dates that we have tracked right here. I just want to call that out so there's not any confusion between last presentation and this presentation. So the Cures Act and the ONC final rule has given us a couple of things to work on. The support for the US-CDI isn't much. There's just a few data elements that we'll go ahead and add. We have the ability to consume the data that's presented to us over HL7v2, for example, is the primary acquisition of data that's stored discretely within the record set. There's a few data elements that aren't very common, aren't commonly collected at the point of care and during care today that are now required under US-CDI. And so as those data elements begin showing up at the point of care, we need to be able to receive those and store those. And so that's something we're working on right now and plan to have that available here this year. So that if those data elements are available, we are able to then store that and make that available through query through the community hub. There are some other elements or other items here that take place further in the future. So just for the sake of time, I'm not going to go through them right now. But I do want to call out near the bottom patient event notifications that was talked about in the previous slide. That is something we're tracking to with our notifications application Notify. That's something we plan to support this year as well, so that we'll be well prepared rolling into next year. Next slide. With the health exchange, so not falling under the CARES Act, obviously, but still with our federal entities that we exchange documents with. The health exchange has had a pretty busy year. They've rolled out their community or their eHealth exchange hub, and through that we've been able to support connectivity with the VA and the DoD through the joint HIE. So that we've been able to certify with that. We support all the IHE queries that maintain the connectivity that we would expect there. Next slide. Next, you can go through the next slide again. Yeah. So a little more exciting is FHIR. There's been a lot of talk of FHIR. That the patient use case of FHIR is really speeding up quickly with the requirement for payers and EHRs to be able to supply patient access and provider access through a standard FHIR API. This requirement doesn't necessarily fall on us as a technology vendor, but FHIR has many use cases, and we understand how critical those use cases are to interoperability and analytics. And so this is something that we have our team right now that develops the community health record or CHR application. They are working on a FHIR preview that will be the first step in an open API that will provide external access to CDRs and other repositories. So this is a pretty exciting initiative that we're pushing off, and this will also become the foundation of the next version of the community health record. So this will be, again, open APIs that we will build applications on top of, and they provide external access. So it provides lots of room for improvement, for innovation, and we're pretty excited about this. Let's go ahead to the next slide. Real quick, just a couple of items that we are releasing in the near term for the community health record is the ability for group administration and security enhancements with two-factor authentication and enhanced SSO. Unstructured documents I'll actually cover here in the next few slides, and I know we're down to a minute, so I'm gonna do this as fast as possible. So next slide, please. Again. So unstructured documents is something that we're close to releasing an update for. This is where so C-CDA documents, commonly we hear CCDs, and that's commonly what's exchanged, but there's so much more within that realm. And so unstructured documents is just one of those. This is the path for that I'm talking about. The scope here is where you have a document source that registers a document to the HIE, and then the HIE makes that document unstructured query through the community hub. Next slide, please. We can actually just kind of skip through these animations here just for the sake of time. So this just gives an overview. On the left-hand side are structured body documents, which we currently support. Those can be provided and registered to the document repository. Unstructured documents on the right-hand side is a non-XML body where you have plain text, PDFs, images, whatever it might be. So there's some additional support we've had to develop to be able to support that document type. Next slide, please. So what we're doing to support this is on the community hub side, we're fully indexing the metadata that comes in, so that metadata is available for the query. So if you were to kind of go from the complete left-hand side receive to the right-hand side query, indexing that metadata robustly allows us to be able to support a number of different queries that aren't necessarily common today, but as you start to introduce unstructured documents and different document types, it allows people to have very flexible queries to be able to get exactly what they're looking for over the IHE profiles. In the middle, so again on the left-hand side, receiving, so we're fully indexing it. We are storing that, persisting that unstructured content, and then we're making that available for display within the community health record, and then for query out through the community hub on the back end. Next slide, please. And the release date for that is Q4 of 2020. And that wraps up what I had for the roadmap today. Sorry for the whirlwind there. I'm always available for questions. If at any time, I'm more than happy to help go into anything in more depth.
Yeah, I think I came up. Yeah. So thank you, Jay. So I know that we're really pressed for time, and so instead of trying to take a sip through the fire hydrant and spin through these last couple of slides, let me just share with you really the work that we've invested in combining an analytic and an interoperability platform to benefit both interoperability and analytic use cases. So if you'll just I want you to go probably 3 or 4 slides to there's a picture. So keep going. Here we go. So what we've provided for is we have enhanced what is known as the data operating system, which is the Health Catalyst Core Analytic Platform. We've enhanced that platform with our interface engine, which many of you are familiar with, which is called Nexus. Certainly the CCHIE team is very familiar with. And so Nexus now supports those real-time transactions for both interoperability and for analytic use cases. So the data flowing in through workflow A is our current state where HL7V2 messages are received. We can save them, patient match them, present them in a notification via the Notify product, aggregate them in our community health record store. Workflow B allows us to then create more of a streaming service where the raw transactions remain available. I share this with you, why does this matter? Why is this important to a CCHIE user group? I share this with you to really compel and paint the narrative that we are investing heavily at Health Catalyst in these interoperability workflows. As Jay just shared with you, we're radically enhancing the community hub and the CDA exchange capabilities. We're continuing to support eHealth Exchange and the VA initiatives. So I just want you to paint that picture that we've not, as an acquired business, oftentimes you think, is this thing going to just be shelved? And I'm sharing this with you because we are continuing to heavily invest in these areas, both from a technical perspective as well as from a business perspective. We are currently participating weekly with calls with the FDA. We have been an advisor to the ONC around some of the interoperability rules, certainly some of the COVID capabilities that have come out. We have been on regular calls with the CDC. So you're seeing us invest not only in technology, but in business. And we'll partner with CCHIE to share our learnings, continue to participate in these kind of great events and learn from your health systems and your stakeholders. So with that, Yvonne, I'll go ahead and turn it back over to you.
Thank you, Carol and Jay. We appreciate it, and Matt and Coleman. And I know it is just a whirlwind of information, and I'm looking at the time right now, and I want to be mindful of folks' time. We do have just a couple of more updates that I'll go through. We do have a short video we'd like to play for you at the end. So anyone who can, if you guys could extend a little bit of time, we'll try to get through these slides quickly and hopefully get to that video. If not, just so you guys know, the video will be available online. The slides are available. And if anybody would like to reach out to our presenters, we'll have their contact information for you. So next slide there is just our CCHIE by the numbers dashboard. As you can see, over the past year, our members have increased utilization, which means increased value by using the community health record during this complicated year. There's about 1.9 million patient lives available in Coastal Connect, and this past year, about 5,000 users accessed the HIE every 90 seconds and performed nearly 5 million patient service searches. Our 295 data contributors have sent many different data sets to the care teams in our region. This includes transcription reports, about 15.5 million of those, and about 161 million ADT transactions. We did welcome 13 new data consumers, and we provided 60 education sessions. Obviously, we're pivoting everything to virtual right now. On the next slide, you can see our integrations that we worked on this year. We did add several new data contributors, and I won't read those to you guys. And our future integrations, we're really excited about our eHealth connections with our state HIE, as well as the Department of Defense and VA. We have our national partnership in queue with the Patient-Centered Data Home. This is a national event notification tool that alerts a home provider when their patient has received care while traveling outside and anywhere in the nation, really. And we continue to focus on local partnerships with folks like the Cape Fear Collective, and they really do a lot of work around supporting health equity, social determinants of health, population health, and community health data projects. And on the next slide there, you can see we did support the community during COVID-19. There was increased utilizations and requests to have access to our community health records patient data set. Just looking for COVID data testing information as people shifted to using telehealth for primary care visits. Our regional health departments, they increased their use of Notify, getting notifications from the hospitals as well as the skilled nursing facilities in our region. We also shared some limited data reports that we were able to get through Health Catalyst. They were kind enough to give us those reports. And then also we were able to generate some of the limited custom reports inside of Coastal Connect data warehouse. And then there's just a couple of quotes that we're playing there on the right-hand side. And on the next slide is just really to remind you guys about Notify. We've talked a lot about the 21st Century Cures Act, being able to send ADTs, what's it going to mean when it comes to the CMS conditions of participation requirement. You heard Health Catalyst's commitment to ensure that there'd be enhancements to Notify, which is a product already in use, available to you today. Many of you use it for multiple different reasons. I would ask that you take a look at our recently published manuscript. And what that was for is CABG patients working with our heart physicians locally in one of our hospitals to reduce readmissions. And it was published in, as you can see there, the Journal of Clinical Outcomes Management. So I know we're pushed for time. We do have a video that we put together, and this is really a compilation of the participation survey that many of you responded to. Thank you so much for taking the time to give us your feedback. And what we're going to give you now is just a message from some of our collaborative partners, and then highlight some of the user stories that you gave to us in the participant survey. It is about 14 minutes long. If you could stay on board with us, that would be great. And if not, we'll have it posted on our website. So I'm going to ask Bobby to go ahead and launch that, and I hope you enjoy it.
Hi, everyone. My name is Kelly Thompson. I am the CEO for CCHIE, which is the Strategic Health Information Exchange Collaborative. Thank you all for being members of our collaborative and for joining us today. I appreciate the opportunity to share some thoughts with you about CCHIE, our work, and what we're seeing on the national front in terms of the HIE community. To give you a sense of some of the activities that I'm seeing going through the HIE community for CHIC. This gives you just some of the numbers to consider in terms of encounter notifications, ADT alerts, and then also alerts, delivered within the HIE. So again, just to give you some insight into the volumes that we're seeing traverse the network. You can see healthcare encounters noted here, immunizations down in that bottom right. That's a big one in terms of conversations around COVID and next steps for the COVID activities. So again, just a quick snapshot of what we're providing in terms of this HIE community. As we surveyed our members, we also learned some exciting news as well in terms of the community partnerships that HIEs offer. Now, this is something that we've always known, frankly, but I think now we have the substantive data to support these community partnerships. Many of our HIEs, as you can see from the chart in front of you, are working with blood banks and school nurses in particular now as we're having the COVID conversations about students returning to school and what that looks like and transitioning in and out of remote or virtual learning depending on your state and district's approach. The partnerships with school nurses has always been important to us as an HIE community, but I'm seeing that increase even more going forward as we are tackling the COVID pandemic and general public health conversations. You can also see dialysis centers as one of our partners. Our dialysis centers, I have seen really utilize our HIE services as we have been tackling hurricanes and flooding and things of that nature, where we have electricity dependent patients who may be displaced as part of a large population that has to be evacuated. And this is both within state lines and across state lines. I know as I've worked with the Carolinas in the past, we've seen many folks have to move across state lines, and we've needed to track those for providers. A couple things that we have learned as we've gone over these past several months of COVID discussions and public health and the HIE role is that when HIEs are at the table and part of not only those COVID conversations, but the natural disasters, the wildfires, the hurricanes, the earthquakes, things of that nature, having HIE leaders in those conversations when you are running the drills, whenever you're having those initial planning conversations, and just recognizing who the key contacts are and how to get providers provisioned within an HIE quickly have been incredibly helpful. The surveillance data has been incredibly important as well, and the need for those lab tests to flow freely, particularly as we're looking at the COVID-19 work, that has been an incredibly vital piece as well. And I do think we've made some traction in terms of working with the labs, but just recognizing the need for that more timely data so you don't have a suspected COVID patient sitting in a physician's office, and we could have known that, but didn't wisely use the data beforehand. You can see before you a checklist of things that we've shared from our advocacy agenda that focuses on basically including us. Let us have a seat at the table. Include us as you're trying to coordinate key social services, key community discussions. Include us whenever you're looking at those emergency preparedness responses. And partner with us, certainly whenever there is an opportunity to work on collaboratives and strategic funding opportunities. I have included a couple of links here, my email, my phone number, our Twitter handle. Please take advantage of these resources within the CHIC community. It really is my honor to work with all of you. I have worked in healthcare for the majority of my career in nonprofit healthcare and public service, and working with health information exchange across the nation has certainly been one of the most fulfilling.
Greetings, Coastal Connect. Hi, Yvonne and Karen. I hope each of you are doing well and staying healthy, and so is your team. I'm thinking about all of my HIE colleagues lately and want to just be thankful for their health and their mission to keep us strong during this troubled times. And greetings also to the Board of Directors. Thank you again for this opportunity to be with you this year at your annual conference. I always enjoy speaking passionately about health information exchange, especially with the great folks of Coastal Connect. And I wish each of you health and happiness as well. Most importantly, I want to express my gratitude and sincere thanks to all of your members who have staff on the front lines during this time of COVID-19 for their willingness to keep our health system strong and treat those patients that need us most during this time. So please express my gratitude and continued good health to them as well. Current state of patient-centered data home is that it is just a collaborative. Every member has signed a governance agreement that basically says we all agree to share data, and we want to do so in a collaborative nature with some standards of how we data share with each other. What we know today is that that's not enough. What we know today is that we need more structure and we need a business model to be able to provide more opportunities for health information exchanges using this PCDH network, which is today the largest health information exchange of data initiative available in the country. We have more transactions happening across the PCDH network than any other network compared to Commonwealth, Care Equality, and the eHealth Exchange. And so to capitalize on that and to make sure that we're doing what we can to demonstrate the value of this network and to show our partners in the federal government and our state governments and to other competing forces in the industry right now, we need to make sure that we advance PCDH to its next level and to its next phase. Again, COVID has shown the light on the value, but more importantly, the need for health information exchange and the services that we provide, and how very clearly COVID has demonstrated that we are very underutilized by most public health entities in the public health infrastructure. And so advancing PCDH and its opportunities to grow is in a way for us to capitalize on the lessons that COVID has taught us when interoperability and health information exchanges are so desperately needed. And so as a leader of the CHIE board and on the PCDH Governance Council, I'm committed to, along with many other colleagues that are working alongside with me, to keep PCDH growing, to advance it, to make it the strongest exchange network supported by all of our nonprofit health information exchanges across the country that are doing the hard work. Nothing exists without the hard work that are being done by Coastal Connect and the likes of others. So message for you today is to keep your chins up, keep doing the hard work that you're doing, keep participating in PCDH because great things are coming ahead. And if you have any questions about any of it, please don't hesitate to reach out to me or others on the council, and be assured that you will be kept apprised of all of our advances to come and the progress to come on our new business strategy and our new business model, which you will surely benefit from. So again, thanks so much for this opportunity. Always enjoy an opportunity to speak with colleagues that are dedicated to advancing the mission of interoperability of health data. And I look forward to seeing you in person sometime real soon. Thanks so much.
I didn't know what to do.
I work with the geriatric population, and most have mild to severe dementia. I send multiple patients to the ER, and these residents are unable to recall a lot of what care was provided to them during their visit. Before the HIE access, all I received about their visit is the discharge paperwork and patient education that is given to the patient at discharge. As a clinician, this information did not give any details about what care was received. Since being able to access these records, I am able to see details about the care provided and the follow-up care recommended. I am able to ensure that my residents' care is complete.
As a mobile clinic nurse, it is important to know where the patient was seen and what previous treatments were provided. In some cases, our mobile clinic is the only option farm workers have to see a provider. I find it very helpful to verify patient history information for our women's health clinic when clients have undergone procedures elsewhere.
Receiving complete detailed report on the patient's condition and history can be an arduous task. Often you wait for this information to be faxed or need a sign-in code for the facility EMR to find out about the patient's condition. Typically, there's only a brief history available. With CCHIE, we are not at the mercy of the fax machine, nor do we have to wait for the discharge planner to submit the information. CCHIE allows us to obtain the patient information sooner. This information usually has more detail and patient history, so we are better informed and get into the patient's home sooner with an improved plan of care.
I was able to schedule a new surgical patient for same-day appointment because I could access the previous records through CCHIE. I did not need to wait for records, and the patient was able to get into the OR for a required surgery that improved quality of life.
We have had newborns not seen by our providers in the nursery. I was able to promptly look them up and enter the information into our system prior to the patient's arrival. Our providers are able to get the patient in and out safely without prolonged exposure in our office.
I deal with many patients that have been seen at the ED or had some type of testing. Sometimes they can't remember, and other times they didn't understand what was explained to them while seeking treatment. The information I find in CCHIE helps me get patients scheduled with the correct caregiver for the right follow-up. You don't want to schedule a patient who has the flu with an orthopedic doctor or send a fracture to a neurologist. It really helps me help the patient to the best of my ability.
The information provided by CCHIE is crucial to our daily operations in our outpatient dialysis setting. We cannot guarantee communication from the doctors or the family. Therefore, a large part of our continuity of care comes from this data.
Thanks to Coastal Connect, I was able to access imaging that dramatically changed the referral process for a gentleman. The referral document indicated a surgical history that we needed supporting documents for before we'd be able to see the patient and make a treatment plan. This website allowed the patient's wait time to be cut down by literal months.
CCHIE ensures patients are on indicated medications for HEDIS measures, CHF, statins, etc., and to complete medication reconciliations when patients do not provide or bring records. Especially during COVID-19, with increase in telephone encounters and reduced patient traffic in the clinic, community health record access has been crucial.
We have used CCHIE since its inception, and it has been nothing short of great. Since much work can be done in pre-visit mode to prepare for the patient, this tool greatly enhances the quality of care provided. I'm able to see all wellness-related screenings such as mammograms, colonoscopies, and pap smears. If the patient hasn't had a screening, I can make the appointments right then.
When patients come in for a visit, they know that they were hospitalized or had a test done, but they're not always aware of what exactly was done. Being able to access this information makes patient care more accurate, and it has also prevented repeated tests.
Thank you guys so much for hanging in there. I'm sorry we did go over a few minutes, but just wanted to wrap up the meeting by saying thank you so much for being a part of our first virtual annual meeting. And thank you for all your participation and support to Coastal Connect. We definitely look forward to working with you guys over the next year. I know we're in for some uncharted waters, so we do wish you and your families health and wellness. Stay safe out there, and we're going to cross our fingers and pray no more hurricanes. And we really look forward to following up with all of you soon. So thank you all so much. Have a great rest of your week.